this woman writes an esoteric medical article that's really fascinating, and I almost never get it right, and this one was really intriguing to me. So this is, he had trouble breathing and inhalers didn't help. What was going on? And I figured in a room of allergists here, maybe someone had heard of this condition I never had. So the diagnosis here is plastic asthma. Anybody ever heard of that? When we teach one another and all the training of all the people in this room. So this is a case, this woman, the physician that this person went to searched the terms cough and bronchial cas, because the guy was coughing up plastic-looking kind of white bronchial cas. And the very first search brought up something she had never heard of, plastic bronchitis, a rare and sometimes life-threatening disorder that involves the lymphatic system. So what happens here apparently is your lymphatic system, where it's about to return all the lymph to your venous system, is obstructed. And so there's high pressure in the lymphatic system. It backs up and cannot drain adequately, including small vessels in the lungs, and then they solidify and make plastic-looking cas. And this person was theoretically, they don't know, born with that anatomic abnormality, and hence you hopefully learn something new. There's this condition called plastic asthma. And I recommend reading this every week. She comes up with the most fascinating diseases in all specialties. Last week, I don't know where last week's speaker is. That's really not acceptable.
8 o'clock.
I already texted her this morning, so I don't.
So last week we had to talk about subcutaneous immunotherapy, and we basically learned in a nutshell that 3 years of treatment seems to be sufficient. It treats very effectively rhinitis and asthma. And something I don't really believe or think that I see routinely is people who have been on for 3 years maintain control for the subsequent 3 years. And that 2 years was not enough, and that it's a very cost-effective form of treatment in comparison to other things we do in our specialty, perhaps notably with a new product being released for peanut desensitization, that by comparison to how much money our specialty may spend to find kids with peanut allergy, it's somebody mute your phone, somebody on the outside. So today the counterpoint will be sublingual immunotherapy, and for those of us who are old enough in this room, which is a handful of old-timers, this form of treatment originally had a very bad connotation. There was no science to it, and a lot of, if you will, off-brand practitioners made their own sublingual drops that were theoretically an effective way of treating asthma and allergy, and didn't work and just had a placebo effect. So I know when a standardized sublingual came on the market, I was at first skeptical and not an early adapter of this. So I'll be interested to see Kez tell us the quality of the science that now backs it up. All right.
All right, good morning, everybody. My name's Kes. I'm always sitting over there quietly, trying not to disturb anybody. So I'm one of the first-year fellows here. And so I will attempt to teach everyone something new today about sublingual immunotherapy. No disclosures. Word of the day is elixir. Magical and medicinal potion.
Elixir.
Elixir.
Of the gods.
So, we're going to review the history of sublingual immunotherapy, and we'll go over the science behind it. So it's been established at this point pretty well at a molecular level of what's going on with mucosal tolerance. And we'll go over that, and then this, kind of go over again the indications for SLIT, review some of the efficacy of SLIT, and some of the other potential things that have been studied with sublingual immunotherapy. We'll get there at the end. Such as it was pretty interesting. There was an article on latex allergy and bee venom sublingual immunotherapy. We'll go over whether or not that's a thing. Spoiler alert: no, we shouldn't. There's not enough evidence for that yet. So as my colleague Kathy last week went over already with the history behind allergy immunotherapy. So Dr. Noon in 1911 really started this off, and it was empiric. We're going after allergenic toxins, and then finally in 1954 we had our first randomized double-blind placebo-controlled study on SCIT, and then the first controlled trial with SLIT happened in 1986. So at that time I was just learning how to ride a tricycle, and the official acceptance of SLIT came in 2009. So when the World Allergy Organization kind of accepted it for the first time. And ultimately there have been over 60 randomized double-blind placebo-controlled trials, up to 2014. So, and 77 trials, I'm sorry, in 2014 already. So again, kind of the overall history that we're seeing with allergy immunotherapy. SLIT kind of comes in to the picture there in the 1980s. So, and then as we head into the 2010s, and I'm not necessarily going to be going into oral immunotherapy with Peanut necessarily with this talk. So,
What are LB? Oh, and LB.
So,
Better.
some of them are injected. Yeah, lymph nodes.
German.
There.
The inguinal lymph nodes. That's like saying.
And so, as far as SLIT for the background, so a lot of it's been happening. The Europeans are using it quite widely. They've been using this a lot more than we have here in the United States. And the overall thing, so with SLIT, we're using a lot more of the allergen, so taking 50 to 100-fold greater large amounts of the protein in order to establish some kind of immunogenic response to it. And so ultimately, the FDA, for us here in the United States, so we have FDA-approved SLIT tablets for Timothy grass, and there's a 5-grass pollen tablet, there's ragweed, and then house dust mite. So that's what's been approved here in the United States until now. So, and then specifically for the house dust mite, the indication for the age is 18 to 65 years of age. And then I just like this table. They kind of outline the other 3 immunotherapies. So with grass tech, with the Timothy grass, it's approved down to 5 and up to 65 years of age. It's been studied. And then oral air, it's the 5-grass pollen one, and that's been down to 10 years of age for kids. And then the ragweed one, it's been studied down to 18 specifically. So, and then
One thing is wrong on that table. I don't think Merck represents those products anymore.
Right.
And I don't know if you're going to get to this, but I think they don't represent it because the sales were terrible. I don't know if you're going to talk about how well this product or this whole form of treatment has been accepted in the U.S., but I think the sales have been very disappointing. Anybody want to comment on that, or did you look into that?
I didn't necessarily look into the business models of it necessarily. There have been, it has been handed over to ALK specifically due to these sales that weren't as, we'll go over some of the attitudes toward SLIT specifically in the United States toward the end there. And so some of the limitations that are perceived by United States physicians, allergists specifically, to using SLIT. So so the companies definitely have changed. So, all right, and so for us, our indications here, so you need to have a positive response to skin prick testing or vitro-specific IgE testing to the allergens contained in the SLIT in the tablets. And then it's recommended that the first dose is given in the office to monitor for anaphylaxis, even though the risk for anaphylaxis really low. And we'll go over that, the safety profiles. And then at this point, allergic asthma is not an indication for SLIT specifically, although we are able to give it, it's the same as SCIT, so basically you're able to give it sublingual immunotherapy to patients with asthma, but as long as it's controlled and it's mild to moderate, but not severe patients or poorly controlled patients. And then if you're going to be using SLIT before the season to kind of maximize its effects during the season, potentially, I've recommended that you start 12 weeks before the start of the specific pollen season. So, and then again, so the recommendations for the SLIT guidelines that come out. So patients with allergic rhinitis or rhinoconjunctivitis, patients shouldn't have cardiac or pulmonary conditions that may compromise, treatment, just kind of like SCIT. And then consider prescribing an EpiPen. So it's not necessarily an absolute recommendation that everyone should have, but consider that. And then you can, consider adjusting the SLIT dose if patients are missing it for more than 7 days, but a lot of times these patients are taking it at home. So, and then periodically having the patients return, making sure that they're taking the SLIT. So,
I don't know how you reduce the dose. These things just come in on fixed dose. At least
exactly.
In this country, that doesn't mean anything.
Yeah. So I didn't quite understand how that would be done, whether you're not going to be splitting talents or anything like that. But
I don't know.
Jay,
you have more European contacts. They have different products in Europe?
No.
I think so.
No, it's the same.
European. Good.
The other thing that's interesting is consider the epinephrine auto-injector, even with, I don't know if anybody, even with SCIT, where we have a greater risk of systemic reactions, most of us don't prescribe an EpiPen. Does anybody here who routinely has patients on immunotherapy have an EpiPen? I don't.
Although we observe them now.
That's true, we observe it, this is home administered.
Yeah.
Yeah.
The other is that EOE is a contraindication, which gets a little fuzzy sometimes.
Yeah. So, and again, kind of going over just the way that these are administered, just to be clear. So the recommendation is that the tablet's placed on the tongue, held there for 2 minutes, ideally, and then swallowed. So, and that's the way that it's administered. And mostly with the side effects, they're most commonly local. You get, initially, most patients report some local irritation in the mouth, some itchy mouth, and sometimes oral swelling has been reported, but systemic reactions have been very rare. And then the local side effects seem to dissipate with repeated use. So, and so going into the immunologic mechanisms of mucosal tolerance, so there are several mechanisms that have been described. So ultimately, there's the induction of secretory IgA antibodies, which bind to foreign proteins and prevent entry in the body without causing local inflammation. There's induction of Tregs, and that they mediate the suppression through IL-10 and TGF-beta1. And then ultimately, the Tregs depletes T cell numbers and induce T cell energy. So, and then specifically for SLIT, dendritic cells are very much involved, and there have been several dendritic cells that have been identified as seen to drive the Th1, Th2, Th17 T regulatory cells. And so specifically when these proteins are placed in contact with oral mucosa, most of it stays very much locally. So, and ultimately the dendritic cells do the majority of the transfer. So, and then there have been studies with radio-labeled allergy, like how much allergen is left after a period of time. And basically, you can see that even after 2 hours, there's there's no outline of a head on the lower two boxes, but basically it's just showing that after 2 hours, there's a significant amount of that protein that's still left in the oral mucosa, so that these mechanisms can take place locally within the oral mucosa. So, And so again, just overall with the mucosal tolerance, this is primarily dendritic cells are involved, ultimately upregulating IL-10, and then getting through T regulatory cells as well, and IgA blocking antibodies that are ultimately decreasing that allergic mucosal inflammation and symptoms associated with allergies. And so more recently, there have been some additional studies done on the mechanism. So, and so again, the mechanism ultimately, we're seeing the same kind of thing with SCIT. So you're getting an upregulation of IgG4, and we're seeing that in most SLIT studies that have been performed, and then upregulation in IL-10, and then specifically with some new kind of mechanisms that have been proposed is IL-35 that has been noted that it seems to be upregulated to also produce that inhibitory, it's produced by T regulatory cells, and it's an inhibitory cytokine that helps build that mucosal tolerance. So this inducible IL-35 inducible regulatory T cell has been kind of used as almost a marker in patients. So, so the number of the TR35 cells in allergic induced IL-35 production is higher in the peripheral blood of patients with allergic rhinitis after successful SLIT. It's similar to that of healthy control subjects. So that's what they've been finding more recently. So, and yeah.
Do they have any reason why so little is absorbed under the tongue? Because we give a lot of stuff under the tongue, gets absorbed right away.
Yeah.
And then this sits there for hours. Do they comment about that?
They didn't comment. There's still a lot of it that is absorbed into the serum. They find it in the serum eventually. But as far as
Making it into the germinal center.
Yeah.
That was, when I did this last year, that was the issue, was making it into the germinal center was the difficulty. It's like such a small part that gets picked up, but yeah, but ABCs.
Is the molecule that big that it doesn't get absorbed? Because you think under the tongue mucosa,
Yeah.
I mean, you absorb pretty much everything there.
Yeah.
It's getting absorbed, it's just making it to the germinal center.
Yeah.
Yeah.
Is that why the dose is so large?
Good question.
Yeah.
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 That was
what they
presumably
think.
my understanding
Yeah.
as well.
And that's a lot of time. We'll mention this later, but that's a lot of why the peanut-related SLIT, they didn't really get into that because the dose is so significant that you're basically doing oral immunotherapy instead. And so that's why a lot of they're not even pushing the research on sublingual, because they're finding you need such a large dose for the peanut and I think walnut it was as well. So sublingual therapy. So. And then the other more recent findings, so there are these follicular helper T cells, and so these seem to be increased in patients with allergic rhinitis, and so they induce IgE production by an IL-4 dependent manner, and then with treatment, they find that these basically go down. So, and these are a more specific marker than just Th2 cells when trying to measure response to AIT. So by following these follicular helper T cells go down, it correlates more with clinical response to immunotherapy. So this kind of dovetails nicely. There are all these markers that everyone's trying to find. Dr. Wambre 2 weeks ago was working on his as well. So, but this is one more thing that I guess this is just in a lab. It's not obviously in a clinical setting yet. And then there are these innate lymphoid cells as well. And so these are cells that are related to NK cells, and they're specific innate lymphoid cells that correspond to T helper 1 cells, T helper 2 cells, and Th17 cells. And basically, the innate lymphoid cells, ILC2s, correspond specifically to patients who have allergic disease and allergic airway inflammation. And so this specifically also, the ILC2 seems to go down with appropriate allergy immunotherapy. So, so just a summary of the variety of T regulatory cells that are upregulated and downregulated pre and post immunotherapy. So, getting into
I have a question for you. So why is it that if we put these tablets of grass in our mouth, you stimulate beneficial immune response and you change the balance? And when a kid puts peanut in his mouth and eats it, he develops an allergic response and doesn't get these protective. Why? What's different about this than natural oral ingestion of a potential allergy? I know you don't know the answer, because I don't think anybody knows the answer. But doesn't that strike you as strange? You know, how does the body know these pills of grass give you a protective immune response, and chewing on a peanut can give you anaphylaxis? Anyone? Yeah,
I'll get back
I feel
to
badly, I don't know the answer either, you know. But that's a critical question, right? How is it that this gives you a protective immune response, all these very elegant cells here?
Yeah.
Well, the same thing for oral allergy, like someone who's kiwi allergic and grass pollen, like why all of a sudden, because we think it's the protein is shared between the grass and the kiwi, and like why does that person have oral symptoms, right? And why, I don't know, and some people go on to having anaphylaxis with kiwi.
No.
Yeah, or what
And we know it's all
always-
because they're grass pollen allergic, so I don't know.
Well, but what really I never have understood is why people are sensitized and get a positive IgE and they don't have clinical symptoms. What mechanism is going on there versus someone who's sensitized and has anaphylaxis? So there's a lot we don't know.
Is
Right.
it is it because the heat level and
Speak up.
acid? Is it because of the heat level or like some pollen proteins are not heat?
Not heat.
Not
They're
heat
either
resistant.
conformational proteins or linear proteins.
Yes, maybe because the peanut proteins is more stable and heat stable. That could be one of the reasons. Heat and acid stable.
Well, I mean, the
That's
answer
one
could
thing.
either be in the allergen or it could be in the immune response.
Right.
I don't know.
I'll work on that.
Yeah.
I'll have that too.
So, yeah.
Perfect. And so,
Most people don't. So maybe.
now the evidence kind of sliding into, bottom line is that we're able to now explain the efficacy, like basically the biologic and molecular mechanism of SLIT. So, and so what we're seeing through clinically has been studied, and one of the first really big randomized double-blind placebo-controlled trials was performed by Dahl and his group. So, and this was a phase 3 trial with 3 years of daily treatment of grass tablet immunotherapy, and this was in Denmark, or placebo, followed by 2 years of follow-up to assess persistence of efficacy. And this is where, and I'm not going to be able to answer the question of why is this 3 years? 3 years keeps coming up, again. So, but I think just bottom line up front, I couldn't find that answer. There's always the 3-year mark of treatment for efficacy.
I think they were just copying what
Yeah.
they had
Right.
already established with SCIT, that 3 years was sufficient.
Yeah. So, and that's kind of, they included 350 adults with moderate to severe allergic rhinoconjunctivitis. I would like to note, it is interesting to note in this original study, and it's a very predominant, so this was in Europe, granted, so the ethnic origin, the vast, 96% were white. So so as far as like ethnic mix and that effect, so just of the patients who they were taking. But it has been replicated in like studies where it has been a more diverse ethnic background as well. So, but I just saw that kind of stood out to me in the demographics at screening for him. So, and then patients were allowed to use symptomatic rescue medications, and then basically patients were treated with active or placebo tablets for about 22 months. And so several things were measured. So specific IgG4 levels significantly rose with the patients who were on these GRAS-Tech tablets. And then this chart indicates basically symptom scores and medication scores in the first season, so it'd be to your left, in the second season to your right, and basically showing a pretty significant difference between the placebo and the actively treated patients. So
The upper line is placebo, the lower shaded area is...
yes. So, yeah.
So just out of interest, compared to some of the data last week said the symptom scores like went to 0. These don't come anywhere close to 0.
No.
But I don't think that says that this is less effective. I just don't believe the data from some of the studies we heard last week. And very rare patients really go to 0. I don't know what you've told people over the years. I tell people they'll get like 70% better on conventional immunotherapy. But the data isn't even that good, honestly. It's more like 30 or 40% over placebo. Placebo is pretty good itself. Placebo makes you about 40% better. So if you add that to placebo, you do well.
The NT literature, you got
Yeah.
placebo.
It was like 30 to 90%.
Huh?
I remember last year, it was like this huge range. It was like 30 to 90%, depending on who you were, right?
Yeah.
Like,
Yeah, and so the next slide, so so there was a big meta-analysis done. So Dahl, this was back in 2008, but fast forward to 2016, and there was like a massive meta-analysis done. So so kind of again, kind of parsing apart, kind of nobody's gotten down to 0 with any kind of scores, but basically again, taking a look at patients who are being treated with SLIT versus not. And so, and they were looking at these total nasal symptom scores instead relative to placebo. And so there was this improvement between the two groups. So with GRAS SLIT, it was 16% improvement, ragweed 17, and then the house dust mite was 16% improvement. And then as compared to, it's interesting. So just take Flonase. So the nasal symptom scores with seasonal allergic rhinitis or perennial allergic rhinitis, wasn't as robust as, and I don't have these like actual mathematical comparisons between the two groups of SLIT versus like moxilocast or loratadine, but nasal sprays are pretty effective. So,
If I really believed that those numbers were correct, I wouldn't recommend this treatment. Who would
Well,
spend this kind of
I
money
think
for
this
for
is one of the
6-7%?
reasons that GRAS-Tech didn't do well, in addition to so-so marketing.
Yeah.
No, I mean, as this perception's like, oh my God, what a waste of time.
yeah.
Are these all in addition to already like standard medical therapy, or is this independent of, or?
My understanding was this was like in addition. So this was like they split out the groups like of
Yeah.
the placebo patients who were taking just the Flonase.
Just the
like,
Flonase, and then this plus
Yeah.
the Flonase. Okay,
So, but bottom line is that
it's not still not
it's
okay.
interesting.
One of the things I remember looking at this initial data is the Europeans seem to have a lot of monosensitized people that I never see in my practice. I don't know about the rest of you, but
That's right.
I have like one person that's grass allergic and nothing else.
There's
So
still-
she's gonna try this, but I mean, I don't have anybody else that's just monosensitized.
Right.
They all live in.
They don't really have patients who are monosensitized. They just focus on the most significant one, and they
Right.
blow off the others. And they sort of assume if you make someone better during grass season, then their immune system is not primed, and they're less symptomatic, even though you haven't bothered with the trees or the weeds.
Right.
there's this priming effect of, you'll be more symptomatic if you go through a grass season untreated.
They're also
But
less
in
comfortable
truth,
doing
huh?
multiple. They're also less comfortable doing multiple.
Well, that's the other problem, is you
allergies.
can't give people 5 different kinds of pills.
Right.
Uh,
But even with SCIT, like they dislike doing multiple.
Yeah.
In fact, there are guidelines indicating you shouldn't do one.
And then here in a little bit, it's interesting who is giving these medications in Europe. So we'll go into Germany, and there's not like allergists necessarily, like there are pediatricians, ENTs, like who gives these medications is also different in Europe as well. So that was interesting too. But yeah, so there's, I think, a lot of differences between us and Europe with. So, I mean, the bottom line, this is just showing the efficacy of SLIT, and grass, and Timothy grass and ragweed SLIT. It does seem to somewhat help with the total nasal symptom scores. So, it's graphically showing that. So, the other aspect that's been studied is this effect of SLIT on the natural course and progression of allergic disease and asthma, especially in children. And so the thought was that they took kids who might be sensitized to either dog or something, or I'm sorry, to one thing, so grass, and if they start treating it with just grass, they don't necessarily progress to being allergic to other things. And so, so that would be one reason that's been shown to potentially use it in children. And so this other study that was done was the GRAZEX. It's a GAP trial. It's the first study to study the effect of AIT in reducing the risk of developing asthma in subjects with allergic rhinoconjunctivitis in a large randomized double-blind placebo-controlled trial. And so they use these grass SLIT tablets and compare them to placebo and the risk of developing asthma in kids. So, and so they took 812 kids, 5 to 12 years of age, history of very specific grass, pollen allergic rhinoconjunctivitis only. And so, and at the time they would have no symptoms of asthma or use of medication that would be used for asthma. And so, and then there were 3 years of treatment and then 2 years of follow-up for these patients. And so what they found was basically for the diagnosis and onset of asthma, there was no difference in the time that it took for the onset of asthma in these patients. But it seemed like the patients who developed asthma seemed to be a lot less severe, and the use of medication seemed to be a lot less in those patients. And so, and so that was kind of what they found. And this graph is just showing, so on the left-hand side, it's just showing the symptom scores between the SLIT treated patients and the placebo-controlled patients, with the blue being the SLIT and just having significantly fewer rhinoconjunctivitis symptoms. And then on the right, it's showing specifically the asthma symptoms. So, well, it's showing, this doesn't really show up too well. So, but yeah. So this specifically, this graph right here just being asthma symptoms, so comparing the two between placebo and then SLIT, so a lot fewer asthma symptoms in the patients who were treated with SLIT, and then a lot less asthma medication use is this chart right here comparing placebo and SLIT, and then this is asthma symptoms with asthma medication use. So bottom line is patients with asthma seem to be doing a lot better on the grass tablets overall. And so, and even your most severe patients, the patients treated with SLIT seem to be less severe and needing inhaled corticosteroids a lot less. So,
Did it change the percentage of kids who went on to have asthma?
yes, so yeah, but
Fewer kids developed asthma? Who were
it didn't necessarily say that necessarily that just the severity was a lot less. Yeah, but not necessarily that it was preventing asthma.
Because I think the data for SCID is better. The SCID actually does prevent the onset of asthma.
Oh, what was the question?
Different.
Oh, I was just asking if I didn't catch it at the beginning of the study, none of them had asthma, or was it?
Correct, yeah. It was, the kids were specifically screened. They only had rhinoconjunctivitis and no asthma medication and no asthma diagnosis. So following them specifically. So, these two graphs right here, so these are a proportion of subjects experiencing asthma symptoms or asthma medication use during winter visits and summer visits. So, and again, between the winter and the summer, the patients who were on SLIT therapy prior to them developing asthma seemed to be less severe. So that's kind of what that's showing overall, both interestingly enough in the wintertime and the summertime as well. So, and then we kind of went over all that. So, so one of the things that the Germans looked at was, so we're giving all this medication, it's expensive, and so what's the compliance and the ongoing use of SLIT for patients? Are they actually using this at refilling? And so they use prescription renewal rates for SLIT tablet and SCIT using the German, their kind of health database between January 2006 and August 2014. And their primary endpoint was to see the proportion of patients who are continuing to use SLIT tablet and SCIT over 3 years of follow-up. So, and so basically the mean age was 27, and less than 10% of these patients had asthma, and the bottom line is that the patients overall seem to, the SLIT patients in the first year seem to drop out more than the SCIT patients. But in the end, the compliance and adherence was the same between SCIT and SLIT after the first year. So the patients seem to continue using it as prescribed, both SCIT and SLIT. So
They did, but it looked like they were equally bad. They were comparable.
Yeah. Yeah. No, exactly. And so this is where it was interesting. So they followed, so who is giving these medications? So these are like your general practitioners, dermatologists, pediatricians, ENT, and pulmonologists. So there's no like allergists anywhere, which is, I don't know how to explain that, but that's, you know, a difference that I just noticed.
Okay, can you comment on that? Are there allergists in Germany?
There are,
Only in this spot.
Yeah.
but, I think that's correct, that most of the practitioners in Europe tend not to bias towards the specialists, but more to the general practitioners.
Lots of SCIT is done here by general practitioners.
Is it?
And they're not, people don't go to, they go to their doctor's office for their allergy shots. They don't always go to an allergist.
Well, I mean, this is home, what I was very surprised when I first saw the adherence rate of people. You know, I figured if you told somebody you could treat yourself at home, you don't have to come in. If you have miserable allergy symptoms, you'd say, great, I'll do that. And then to learn that like a year in, less than 30% of people stick with it, I guess it's just a statement of human nature that you can lead people to horses or people to water, but they're too stupid to continue. Right? Isn't that about what it is? About 30% of people stick with it?
Yeah. Yeah. So, so that's the adherence. And so with safety, so overall in adults, it's been noted that the majority of side effects have been very much localized, and this was a good study more recently done specifically on children with SLIT and just proving that it is safe with kids. And so this was a meta-analysis done to assess short and long-term tolerability and safety of Timothy grass, SLIT in children. And so, and this was a combined effort, looking at European and North American trials. And so the most common, but again, the kids seem to replicate the same thing as adults, and the most common side effects were primarily local, and so and very mild to moderate in severity instead. So it seemed to be primarily oral pruritus and throat irritation, and about 8% of the patients in the SLIT trial seemed to discontinue due to these symptoms. So something to consider. And so, but only like one systemic response needing epi. So for kids, it seems to be safe. So what do we think about this? So this group took a look at the perceptions in the United States amongst physicians who are in the college. So, and there are 305 respondents, and so, and of those respondents, about 88% practice in the United States. And so, this is what I found surprising. So, of the allergists who are using this, 68% use SLIT only FDA approved. So there's a pretty significant amount of us who are using SLIT that's like not necessarily FDA approved. So I found that.
But are they board
interesting.
certified allergists? I guess they must be.
So this is, yeah. So like,
Wow.
I just found this interesting. Like,
This goes back to what I said at the beginning, that especially ENT, but maybe allergists as well, have been making up their own elixir, the word of the day, for a long time with no proof other than placebo effect. And you tell people put drops under your tongue,
And the
40%.
concentration is very, very low of those drugs.
I don't even know what they use.
It's not
Whether
standardized
they
at all.
use the material that we use for diagnostic skin testing to tell people to drink or swallow. So that's how this, at least from my perspective, that's how this had a tainted impression even before these products came to the U.S. market. And I still see people once in a while who are getting drops from their, I don't know from what.
Yeah.
When you said 68%, is that using it off-label or using another product altogether? Because they used to tell you just to use it during the grass season and stop during the off-season.
Yeah.
And that sort of fell out. Now you're using it all the time. Is that in your 68% group?
So I don't think it parsed out that much. It just said that of the respondents, that they only use the FDA approved and didn't combine it with, because it did break out a little bit later. So where about 24% of the respondents were using both FDA and some other form of, whether it's these skip drops used sublingually, that was also mentioned as well. So to me, I find that's pretty significant practice variation. But just to make note of that. And so these are all the things that are being used for SLIT that they found. So, but again, for us, the only top 3 there have been approved in the United States for sublingual immunotherapy through tablets. So,
Did you find any papers of combining, even with legitimate products, combining 2 legitimate products for treatment, for dust mite and grass? They studied combining them?
I haven't seen it.
I think that's the other reason that it's been hard for American allergists. We're used to combining 10 things in SCIT immunotherapy and seeing efficacy. And you only use one thing, it's much more limiting.
Yeah, and so these are the main reasons why it seems like, what were the barriers to use of SLIT? And so it basically comes down to like this question of like, we have patients who are sensitized to numerous things, and are we really going to use only a single product to target that? There are only 4 FDA approved products, and I'm not as familiar with like reimbursement issues, you know, and whether insurance coverage, you know, what that is like for patients going on SLIT. But again, what everyone has mentioned so far, that at least like the top two there. So you're just treating one allergen, and then there's 4 products you're looking at right there. And so other things that have been used, just briefly, just to mention that I guess it's more for awareness sake what's been out there. So, you know, there have been case-controlled studies of venom and SLIT versus SCIT, but there basically, there are limitations to this. So one, side effects. So even with SLIT, there were significant side effects noted with SLIT with to wasp sting specifically. So there's risk with that. And then with the overall shortage of venom, to study this effectively using a much higher dose for sublingual therapy, nobody really wants to go into that necessarily. So, and then the thing with latex specifically, there was a study that looked at latex specifically, latex SLIT. It actually seemed to clinically improve the patients who were going on SLIT therapy, but the side effect profile was pretty significant. The safety profile, many of these patients anaphylaxed. One of them needed like multiple rounds of epi, and so people have been kind of avoiding that as well. And so there's also no commercially available extracts for that here in the U.S.
Did that correspond with people who had related allergies to foods that might be related to latex?
I didn't see that in that specific outline.
Why would anybody even think of doing this? It seems either of these things. It both seems, no, I don't think just,
Yeah.
I mean,
Because they got a grant.
venom allergy is
They got a grant.
injected, not inhaled.
Right.
That doesn't seem to make any sense in it. And latex allergy has basically disappeared with this people not using latex products and finding substances. It just seemed like stupid ideas.
Yeah. So I would not sign up for that trial. And so one of the interesting things that the bottom line with this chart needs to be looked at a little bit more closely is the effect of dust mite sublingual therapy on atopic dermatitis. And there does seem to be some clinical benefit initially shown. There haven't been too many like very large randomized double-blind placebo-controlled trials on dust mite sublingual therapy for atopic dermatitis, and that's kind of the biggest limitation with the strength of the recommendations for that. But there does seem to be, you know, a potential indication for that. And then we kind of touch base on when food and SLIT, the doses that are needed to cover you for peanut basically are going to be significant. So with peanut needing, you know, 2,000 micrograms weekly, you know, it's just everything's been going toward oral immunotherapy instead of sublingual immunotherapy. So my big takeaway from all this was basically, if you have the right patient with grass allergies, rhinoconjunctivitis, it seems like a safe thing to use. And so, but otherwise, you got to find that right patient is be very discriminatory. You know, but that was my big takeaway after all this.
So you showed earlier that the dose of allergen and the SLIT is 50 to 100 times normal. So what's so different about the oral mucosa as opposed to the mucosa of the eye, the nose, and the respiratory mucosa, where minor doses of that will give you symptoms? And you didn't show a lot of reactions.
So some of it, they think so. Some of it could be like enzymatic breakdown in the mouth sublingually. You get that response as well. So you're not being direct and like injecting it, you know, subcutaneously. That was kind of my biggest takeaway from that. I'm not sure, like, specifically, like, because you're not getting...
Are the resident immunologic cells in the mucosa that different from the mouth to the eye? I mean, it doesn't make any sense.
I don't know.
Yeah.
I don't know.
Do you have any idea I mean, in my experience, in well-selected grass allergic patients, it does work.
Right.
And I think it works better than 16%. I mean, I wouldn't
No, I
tell
agree.
people to spend money for a 16% improvement.
Right, no, I agree.
Which is worse than placebo, actually.
It's the 16% on top of the 40% placebo
Yeah,
dose, so
yeah.
that's why we see 56%.
One of the big problems I know we had, if you bring people in and give them the first dose in the office and you haven't checked whether their insurance is going to cover it, then they go to try and fill it as a prescription because you're not making the vaccine for them. You're selling a commercially available tablet. The sticker shock of how expensive it is, then they don't fill it, and that first visit to give them a dose is wasted.
Right.
So I think we've changed our policy and, write them the script first, ask them, go check what it's going to cost you to have at least a 3-month, if not a 12-month supply before we initiate it, otherwise it's wasted. I don't know,
Yeah,
Frank?
well, having said that, I know ALK now has a thing where they'll subsidize the first year of therapy. So it's the copay is very low. And I think the thought process, if the patient sees that it works well, then they'll have to deal with year 2. But so those are available as an option. We have them in the office.
Yeah, I've never
So, but,
understood
yeah.
someone's paying the bill for these subsidized things that we give away.
Yeah.
Nothing's free in America.
No,
So
exactly.
somehow society's paying the bill for this.
Yeah.
Well, the other thing is, we all know the compliance data for people taking pills every day is pretty abysmal. So, I
Yeah.
mean, none of these people are going to take 365 pills in a year.
No,
If they get 6
exactly.
a week, they're doing really well.
Yeah.
So you just wonder how much compliance has to do this, because with the allergy shot, you don't show up, the nurse yells at you. You need to come back. They have a schedule. They have to stay on the schedule.
No, that's
You
exactly.
just wonder if we're encouraging compliance,
Yeah.
subcutaneous versus this.
And also, if you do the math, doing the pre-seasonal, like over 3 to 4 years is a lot less therapy and cost than doing it year-round. Having said that, there was a more recent study with Grass Tech showing that the longer you do it, like 4 years, you get it 2 years instead of just 1 year. If you do 5, you get like almost 3. So it does modify the disease, but again, and then that gap gets closer versus doing it half the year. But it's still very expensive. And to me, I think, I remember, I almost laughed actually. I got 3, trying to get this approved when Grass Tech came out, I got 3 responses saying they have to fail SCIT. And I was like, what?
That's interesting.
So clearly part of it was a response that this was not going to do much. And the insurance company was just throwing money out the door. And they're going to end up on SCIT or something.
Part of the
it's
question, how we got to
interesting.
3 years.
Yeah.
Catherine showed a study last week, but she only took out the SCIT data, but it was actually a comparison of 2 years of treatment of placebo, SCIT, and SLIT. And both SCIT and SLIT, with only 2 years, failed.
Yes.
So people have, pushed the envelope and said, well, 3 seems to be enough to give you a couple of years of remission subsequent to it. 2, you start to fail again within the next year. Right? So that's somehow magically how we've come to 3 years. So, as I've said a couple of times, I don't think it's as good as those studies show. I see people who've been on it 5 years and they come back 1 year off and they say, my allergies are back. You don't produce tolerance. Maybe 70% of the time you produce temporary tolerance, but some people fail pretty quickly. All right, next week I think we've got a mixed agenda. We've got journals, and then Clint is going to finish eosinophilic GI diseases. The other thing I forgot to mention, this is somewhat related to oral treatment. On March 10th, we had an opening, and so I have Steve Tcells is going to come. Steve is with Immune, the people who just came out with a oral peanut product. And so it'll be a non-CME talk because he can't say anything about his product or anything commercial, although Steve, will be a good educator and certainly not going to be here to push his product. but hopefully there'll be a lot of interest in that. So March 10th, he'll be here. It'll be non-CME, but it'll be about oral peanut immunotherapy.
Because
All
is
right.
Grazax, is that just in Europe, or is that, we don't have that product in the United States, do we?
Which one?
Grazax?
It's their product, I think.
Is it any different than grass
I
tack?
think it
it's the
is,
same
I
thing
think
with
it is
grass
grass
tack.
tack.
It's the
This
equivalent.
is the European name, I think.
Yeah, that's the way, yeah.
That's sort of disappointing.
Interesting to me how much human effort and study and research goes into something of marginal value. You know, and then, you know, once you've gone down this track of wanting this product to work, how much continuing effort to sort of salvage it and make it viable.
No,
They're throwing money away. That's your
highly
career.
motivated.
I gotta make this work. They've given me all this money. I
Oh,
gotta make this work.
is there a way, I know the, as Megan was saying, which I think is true, that the order, the NDB spiral order, is really a hit, where it was activated